Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology, and totally free. Derms on Drugs is where cutting-edge derm meets hit-or-miss comedy. I'm Matt Zyrus, and each week I'm joined by my residency buddies, Dr. Laura Ferris and Dr. Tim Patton. We use our 60 years of combined experience to discuss, debate, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of derm, and it'll be the most fun you've ever had while actually learning something useful for work. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and wherever else you might decide to get your podcast from. So this week we've got one of our patented six-pack episodes where it's kind of the equivalent of sitting on the back porch and cracking a six-pack and talking about what's been the latest, coolest stuff that you've seen in the literature. So we are going to go ahead and start this week with Dr. Ferris. Ferris, what do you got?
So I'm going to start with a paper from JAMA Dermatology by Ran et al. Risk factor number and recurrence, metastasis, and disease-related death in cutaneous squamous cell carcinoma. Okay, so this is from the group really that came up with the Brigham and Women's Hospital or BWH T-staging for cutaneous squamous cell carcinoma. So really that is a staging system that uses the number of risk factors to stage. And so they have 4 different tumor risk factors that are used. And however, it's not really precisely, according to the authors, precisely associate the number of risk factors because Brigham and Women's stage 2B includes squamous cell carcinomas that have 2 or 3 risk factors.
Do you remember offhand what the risk factors are in the Brigham?
As it turns out, Dr. Zyrus, I do. They are, number 1, a diameter of 2 centimeters or larger. Number 2, invasion beyond the subcutaneous fat.
Wait,
number 3,
not into the fat, beyond the fat.
Into.
Okay. All right. Yeah, that's okay.
Yeah.
Okay.
Large caliber perineural invasion and poor histologic differentiation.
Okay. So those make sense. Those make sense. Okay.
Yeah. So basically 0 risk factors, you're a T1, 1 risk factor, you're a T2A, 2 or 3, you're a T2B, and 4, you're a T3. Okay. So that's what they looked at. So what they said was,
hold on one sec. So site doesn't matter.
Site does not matter in Brigham and Women's.
Lip, ear, and scalp.
Nope.
Okay. All right.
That does not matter. What I've always thought was interesting also is immunosuppressed status does not matter either, right? So that's sort of interesting. So the outcomes that they looked at were 5-year cumulative incidence of local recurrence, nodal metastasis, distant metastasis, and disease-specific death. And so what you can find is that if you look at, if you look at the number of risk factors and you look at the cumulative incidence of these outcomes by risk factor, basically it goes up with each one. So, 0 has fewer than 1, which has fewer than 2, which is fewer than 3. So you can sort of break down that 2, 3, which is fewer than 4. And that's pretty linearly, that trend is seen by risk factor number for all of those outcomes that I mentioned. And so, basically squames with 3 risk factors had more like 1.6-fold higher local recurrence, 1.9-fold higher nodal metastases, and 4.3-fold more distant metastases than those with with 2 risk factors. So it does suggest that we probably should be looking at the number of risk factors, not just within the T2B group. So that's kind of the take home point of this.
So what do you do?
Sort of makes you wonder why did Brigham and Women combine those? Have we talked to Brigham or Women?
I'll call them both.
We're talking to a woman right now, Patton.
Yeah. So you're going to go to Brigham.
This seemed so obvious. I never thought about it when I, would go through the Brigham and Women staging. And then it's the same exact risk factors. It's like, well, of course, why not separate 2 versus 3?
Right. No, it's a good point. but it did not. So why does this matter? I think is like, I was like, why are they doing this study now, right? We probably could have intuitively said that. So, much like we are, sort of had our like this all these studies of like adjuvant therapy and neoadjuvant therapy for melanoma that we've talked about on our podcast before. There's also been data for like neoadjuvant therapy for advanced, squamous cell carcinomas, but adjuvant therapy, meaning you've got a high risk squamous cell carcinoma, you've removed it, now you're going to give immunotherapy. It's sort of going to be the next, I think, renaissance in treatment of patients with high risk squames. So when we think about adjuvant therapy for stage 2 melanoma, right? So it's like, do you give this patient nivolumab or pembrolizumab for their stage 2B or 2C melanoma? There is a lot of debate over who is high risk enough that their disease will return, that we want to actually give them adjuvant therapy, right? So I think that this is all about better stratifying that intermediate, that T2B group, to say, okay, maybe the number of risk factors you have is going to be important. And maybe, for example, we might want to think about giving adjuvant treatment to the really high risk, the 3 risk factor, not the 2 risk factor. So I think that's part of it.
Would you, at this point, what is your cutoff for sending somebody with a squame to see an oncologist or a surgical oncologist or somebody who's more than a Mohs surgeon?
I think if they have at least 2 high risk features, I'm going to probably discuss it with the tumor board if they have one. So diameter of 2 centimeters or larger, maybe not, but invasion to fat, perineural invasion, poor histology. I mean, those are all things that are going to at least lead me to have a tumor board discussion and to consider, potentially like, do we want to do adjuvant radiation, right? So those are all factors that would lead me in that direction. So now
99.9% of dermatologists who do not have derm providers who do not have access to a tumor board. So so really our choice is, well, I can send them to a surgical oncologist or a medical oncologist, and they're going to send them to a tumor board essentially. So the invading into fat, big perineural invasion, and undifferentiated, any of those 3, you are at least going to think about it.
Yes, I am going to think about it. And I would also put in there, particularly in the immunosuppressed transplant patient, right? So that's where it's really going to matter. But so, what is coming down, I think, the pike that is going to make this interesting is the idea of adjuvant therapy. So, now we're like, should we do adjuvant radiation? We've treated them, we've removed their squamous cell, maybe they've had Mohs, their squame's gone. Do we want to do adjuvant radiation? So radiation after. But now there have been 2 studies looking at adjuvant PD-1 inhibitors in this group. Interestingly, we do not have, like, I cannot present that paper, which I would if that were like my option, but there's actually like press releases with information or top line results. So first one is called CPOST. So this was adjuvant cemiplimab for the treatment of high risk cutaneous squamous cell carcinomas post surgery, and so they showed that they reduced the risk of recurrence or death by 68% versus placebo. So patients, that's a pretty big impact. So this is really the first.
But if it was 1 person in 1,000 died, and now 1 person in 1,500 died.
No, this is high risk cutaneous squamous cell carcinoma. So we'll get to like dissect all the data. I mean, you would not do this in a patient with like, the run of the mill squames that we see that are a centimeter, not, no perineural, well differentiated. You would not be putting them in the study. In fact, they had to be, the criteria to go in were pretty high, like, so like perineural was like a named nerve, for example. Then there's another study, interestingly, Keynote 630, which was basically kind of the same study, but with pembrolizumab versus placebo. And that one was at the time at interim analysis, it didn't meet its primary endpoint of recurrence-free survival. And so it was deemed unlikely to meet the secondary endpoint of overall survival. And so they actually stop the trial early. So very interesting that one group, one had this like phenomenal result, and then the other one got pulled early. They're both PD-1 inhibitors. So, there's some like you could speculate. People have speculated that potentially in C-post, the cemiplimab study, that those patients were a little bit higher risk, and so there's a little bit more room for benefit than you saw in the inclusion for pembrolizumab.
But 68% versus nothing is pretty hard to explain just on, well, they were a little higher risk.
Yeah.
So it may matter. So I think it's going to become very important to think about like who should be getting adjuvant therapy, and do we have criteria to predict who's going to benefit or not?
Okay.
What I thought was odd about this study is when you look at NCCN guidelines for cutaneous squamous cell carcinoma was they don't look at number. Well, they kind of do, but one of the things that stands out is perineural invasion of a large caliber nerve. What is that? 0.1 millimeter, right?
It's usually considered 0.1.
If you have that and that alone, it is like, yeah, you know what? Discuss adjuvant radiation therapy with those. It's almost like some risk factors are worse than others, as opposed to number. And so I thought that was kind of weird of like, yeah, okay, you have 4 risk factors, that's going to be worse. But if you just have one risk factor and it happens to be perineural, where that jumps you up to, let's start discussing, should we advance therapy or, add some sort of adjuvant therapy in these people?
And I'll say intuitively that makes sense to me. I mean, it should.
Yeah.
Why would we think that all risk factors are the same? Right? Like, being a diabetic with a hemoglobin A1C of 14 is a worse risk factor for cardiovascular death than is, having a blood pressure of 132 over 92. So like it intuitively it makes sense. Doesn't mean it's right, but intuitively it makes sense.
Yeah. So staging is sort of a blunt instrument for risk stratification, right? So, I think the thought is, are there ways that we can have more, sort of fine risk stratification? So that's where gene expression profiling comes in.
Mm-hmm.
That's where looking at, different the different risk factors. So like a lot of times even in melanoma, like we have nomograms that will predict risk probably better than staging alone. So I think that's where we're moving sort of as a field in oncology or cutaneous oncology, is more sort of granular risk stratification.
And speaking of that, in one of our early episodes, our first or second one, so for anybody who doesn't know, on the Scholars in Medicine website, for each of our episodes, we have links to all of the articles. We have I think it was in the second episode, we have a link to a online risk calculator with melanoma that Dr. Patton, right? Do you remember what it's called?
Nope.
Yeah, but if so, you type in like what's their age, where on their body, it has like 10 different factors.
There's an AJCC one, I think, and there's like an MIA one, the Melanoma Institute of Australia.
I think it was the MIA one. That sounds right. Yes. All right, let's move on to our second article here, Dr. Patton. What do you got?
All right. My first 6-pack paper was Impact of Oral Precancerous Lesions on Oral Cancer Development in Patients with Oral Lichen Planus, a retrospective cohort study of 318 oral lichen planus patients by Chu et al. In the March 2025 edition of Frontiers in Oral Health. I think oral LP is challenging to treat, and I remember learning in residency risk of oral SCC is higher in patients. Wasn't that high. I always use the 1% number when I counsel patients about SCC risk when they have oral LP. So it was funny. I was asked to give a lecture to a bunch of maxillofacial pathologists. So I started looking into the OLP thing. Maxillofacial pathologists, there's actually this controversy where, if you have run-of-the-mill oral lichen planus, that is not precancerous. And so why are you calling it that? It's the patients that have OLP with like other atypia. And like, it's kind of funny to read about. They get all like, they kind of get bitchy towards one another. Like, this person said this and it's a bunch of garbage. It was kind of funny. But anyway, that's kind of an aside. This was a retrospective review of 318 patients with a histopathologic diagnosis of OLP at a single institution in Taiwan between 95 and 2018. They then divided those patients into those with and without oral precancerous lesions. So that's OPLs, not OLP. It's very confusing. So in this study, verrucous hyperplasia, mild to anywhere from mild to severe atypia, that was what it was considered an oral precancerous lesion. 207 OLP patients without premalignant lesions and 111 with premalignant lesions were more common in patients younger than 50, males, people that drank ethanol, chewed betel nuts, smoked, had candidiasis, had oral cancer. The overall rate of SCC was high. Overall, like in all of the 318 patients, oral squamous developed in 10% of patients. That's way higher than, 10 times what I would tell people. It was higher in patients with premalignant lesions, so 20% in that group compared to 4% of patients without premalignant lesions. But even the 4% is kind of high just for normal LP. Now, this is this is an Asian population, and there may be risk factors in that.
I have a vague recollection that it was in particular ulcerative oral lichen planus. Like normal, like Wickham stria, stuff on the hide was no problem.
Because you biopsy that, you're probably not going to see much in the way of atypia or the other things that, these very strict pathologists are like, that's the high risk patients, not Wickham stria, where you're just going to see, the lichenoid infiltrate without significant atypia. You start getting erosions, you start getting like the atrophic form. There's all these other precancerous changes, leukoplakia, erythroleukoplakia, things like that. Right, you're going to see that more in probably the lichen planus that is clinically more severe. I think that's probably true. The second table showed what was associated with the development of oral cancer in OLP patients, and you had statistically significant higher hazard ratios for cancer were seen in patients with premalignant lesions. That makes sense. Patients over 50, ethanol drinkers, patients with kidney disease. That was kind of weird. The one thing that they had never been reported that they thought was interesting was cutaneous LP was more common in patients without premalignant lesions. So like cutaneous and mouth, less likely to have the premalignant lesions, which that had never been reported before. There was a figure that showed 10-year cumulative incidence rate of oral cancer, and it was higher in patients with premalignant lesions than one would anticipate. So just a little bit more info on lichen planus and cancer risk that I thought was kind of interesting.
So what is your threshold for, hey, maybe you better go see somebody? Like, because do you send them to their dentist, or do you have to find an oral pathologist?
I think you're best off finding like either like a
OMF, oral maxillofacial.
like an oral maxillofacial surgeon. I think they're much better with kind of the medical stuff. I think ENTs are very, very good at cancer, but when you start getting into, I think this could be lichen planus or MMP, I have found that the oral maxillofacial or like the dentists that also have a medical degree, they understand the medical side of mouth stuff a little bit better. So we happen to have a dental school at Pitt. It's very, very helpful. A lot of those physicians actually will do the procedures, and they do histopathology. So they really understand the diseases, I think, a lot better.
All right. So if you have the so just thinking about, right, we have listeners in big cities and listeners in the middle of nowhere. Top choice would be an oral pathologist. Second choice would be an OMF guy, or would those be the same? Or
not
OMF.
necessarily the same. Yeah, right.
Okay. And then an ENT, and then sort of after that, like if you're in the middle of nowhere, and the only thing around is a dentist is still better than us.
Yeah, doing the biopsies. Yeah, I think so. Yeah.
Okay,
Unless
fair.
you're comfortable doing, which I am not, but if you were comfortable doing the biopsy, then it's fine. And your derm path could probably read that fine.
Right, what I'll do is like oral lichen planus patients come in. I see this sometimes with the pemphigus patients too, and it's just like a bunch of the things get better, but they still have this one erosion, or they start to develop like a macerated hyperkeratotic whitish. That's when I start thinking, all right, this may be like progressing or getting to one of those pre-malignant lesions where maybe they're going to see the dental person on a regular basis instead of just coming to see me.
Right, the erythroleukoplakia, where the ones that are like the strawberry red and white are worse than if it's just white and worse than if it's just red. But all right, let's move on to our next one, which was mine. This is the first big publication of a new drug that we're going to be hearing a lot about over the next couple of years. So Remibrutinib in chronic spontaneous urticaria in the New England Journal of Medicine. First author was Dr. Hyde. And so essentially the takeaway here, Remibrutinib, extremely effective and very fast. So the big takeaway here, Remi is a Bruton tyrosine kinase inhibitor. And for anybody who's in allergy or oncology, that is a little bit scary of a thing, because Bruton tyrosine kinases are actually used for treating real cancer, and they can have real adverse events. And so there's some element of like, oh my gosh, a BTK inhibitor for something like urticaria, that just seems like too much. But Remi is a extremely selective BTK. And the way that you want to think about this, the drugs that we've had up till now, right? Antihistamines block histamine after a mast cell releases it, right? Omalizumab, you think of that as trying to prevent the mast cell from degranulating by either blocking the IgE or blocking kind of the Ig from getting to the Ig receptor. And it's pretty effective. So about 2/3 of people will do really well with omalizumab, but it usually takes a month or two to really start working. BTK is downstream from that. So BTK is after the IgE binds to the mast cell, the Bruton tyrosine kinase that Remi is inhibiting is part of the pathway from that cell surface activation to degranulation. So you can almost think of this, and I don't want to give anybody the sense it's like a JAK inhibitor and, you know, the adverse events and immunosuppression and whatever. It's not. But it's kind of the same idea that it's an intracellular blocking the signal from the surface to cause the degranulation, unlike omalizumab, which is trying to block the signal on the surface. So this should have broad applications. So Remi, it's the first thing we've ever had that really effectively prevents degranulation. It should work in regular allergy. It should work in CSU, which we now know it does. There's even some belief now that it's going to work in atopic dermatitis. There's studies going on for hidradenitis. For anybody who hasn't listened to our episode with Dr. Dan Kaplan, we get into a little bit about, turns out the mast cells have a much bigger role in cutaneous inflammation and immune responses than we used to know. And Remi is the first drug we're going to have come to market that might really have a broader spectrum effect on mast cells than trying to prevent IgE from activating them or trying to prevent the histamine from doing something afterwards. But the big takeaway is how, I guess that was the third thing that I just said, the big takeaway for. So the other medium takeaway, just how fast the drug works. So within the first days, you're typically seeing people start to get relief, and then very consistent and durable relief as well. The other thing that's going to be interesting, though, is it's a BID drug, and it has anything that has a really rapid onset of action, it has a really rapid loss of onset of action. So we may see people literally, like if they forget a dose before they go to bed at night, they may wake up with itching, like is a real possibility. So it'll be interesting to see how that part plays out as well. But that's kind of what I got for Remi. Thoughts, comments?
Yeah, I thought it was, I mean, it looks promising, right?
Oh, wait,
And
I forgot one thing. The only
yeah,
adverse event, 3% of people get petechiae,
okay.
but
Yeah.
no cases of like, you know, it being like acting like vasculitis or something like that. It's just petechiae with no clinical relevance.
Yeah. No, I think it's interesting. We definitely need more CSU treatments. I believe that so what's going to be interesting is when we start to have head-to-head studies, right? So I believe we're going to have head-to-head with this and dupilumab at some point.
And I would imagine this with Xolair as well, because Xolair's, I think biosimilars are just coming out for Xolair. So if they want to be considered as first line therapy by insurance companies, they're probably going to need to generate data saying we are better than them if they want any chance of getting on formulary ahead of a cheap biosimilar.
Yeah, not that you can compare cross trials, but I did go back and look at the omalizumab trials. Like omalizumab numbers, using the same sort of mean reduction or whatever in the USA 7. Little bit better. I know it's two different trials, but USA 7 seems like that's probably
and it's UAS 7,
UAS.
urticaria.
USA.
Yeah, USA, but this was a UAS.
Yeah.
The biggest benefit of this drug over omalizumab is how fast it is. It is just like almost instant. First dose, people start to notice a benefit from the people I've talked to who did the trials.
And, just how much easier to have an oral medication than like omalizumab's a pain to give in the office
First
and monitor.
doses in the office. Yeah.
And this, with how rapid it works, CSU is another one of the conditions where once people are doing well on Xolair, they're often like, can I stop it? And you're like, oh, it's going to be such a pain. And then we have to get it covered again and the whatever. This, they can much more be like, hey, I haven't had anything in a month. I'm just going to stop it. If my hives come back, I'll start it back up. I've got, my bottle sitting there.
What the only advantage I thought to omalizumab would be with potential monitoring. It seems like these used to be used in cancers. You're monitoring them all the time. You're just kind of freaked out about it. Like if we use this in cancers, like we're gonna have to check CBC and LFTs.
I don't think there's any. It's selective for a different BTK. I don't think there's going to be any monitoring.
Cool.
We'll see. I mean, the lab data looked fine, right? Like it did not look concerning.
It was that petechia, but the platelets, I don't think.
Yeah, the platelets didn't go down. It was
INR was fine. So I think it's going to be interesting. And they were on concomitant antihistamines too, right?
Yeah. So in the urticaria trials, it's always that people are on a stable dose of antihistamine coming into the trial, and they're allowed to stay on it throughout the trial. It's a much better way to do the trials. It's how we ought to do AD trials, where you're on a stable topical regimen rather than you have a washout. And it actually makes a lot more sense, but it's harder to show that your drug works in that situation.
Good.
Yeah. All right, let's move on to our next article here. Dr. Ferris, what do you got?
So I have the study on systemic therapies for psoriatic disease and serious infection in older adults, Drucker et al. From JAMA Dermatology.
Oh, wait, Drucker et al. We're going to have Dr. Drucker on in a month or so to explain to us how meta-analyses get abused in the world of dermatology.
Okay.
How drug companies manipulate them in order to make their drugs look better.
Great. Well, this was not a meta-analysis. This was a cohort study.
Okay.
So but it was in Canada, our sworn enemies. So keep that in mind.
Let's not talk about this paper. Let's talk about USA scores and urticaria.
Exactly. So this was health administrative data from Ontario, Canada. So it was over 11,600 people, 66 and older with psoriatic disease, who were given their first systemic medication basically between April 1, 2002 and December 31st, 2020. And so data analysis was like November 21 through August of 24. So this was not like a case control or they didn't have a control group who didn't get them. What they did was they looked at sort of people began accruing person time in a medication category on the day that they started a new medication. So you may have like your methotrexate era, and then you may have your Humira era. And then you would accrue data as long as you were on that. And then once you stopped it, they sort of had rules as to when you were considered off of it. So they looked at basically 5 different categories. So, who were these people? Psoriatic disease, 73% of them were just skin only, cutaneous psoriasis, not PSA. So they looked at 5 categories. 5 sort of exposure categories: methotrexate, older systemics, your acitretin, cyclosporin, TNF biologics, other biologics. So these were basically your IL-12/23 and IL-17 inhibitors, and then tofacitinib. So what they looked at was time to serious infection. So that was hospitalization, but your main reason that you were hospitalized was because you had an infection, or it could be death from infection. And so a lot of these patients, like about half of them, were in the methotrexate cohort, and about 12% overall were hospitalized for infection. So
in the methotrexate cohort or overall?
no, sort of overall.
Okay.
Okay. So most common infections, pneumonia was number one, UTI, sepsis, cellulitis, and then COVID. There were 36 hospitalizations for COVID-19. So if you look at the hospitalization rates per 100 person years, right? So a person year is one person exposed for a year or two people exposed for half a year each. So rates per 100 person years, 2.7 for methotrexate, 2.5 for older systemics, 2.2 for TNFs, 1.4 for other biologics, and then 8.9 for tofacitinib. So, I mean, I thought that was really kind of, that to me was the most interesting. What's that?
What was the reference group? Wasn't the reference group like?
Each group is sort of, there is no reference group. So well, no, that's not true. Obviously it has to have a reference group. The reference group is time not using that medication class. So compared to everybody, on a drug that's not tofacitinib, that's sort of your reference group. And that's really more, so the person years thing, the numbers I just gave you, those weren't relative risks. That was just, number of hospitalizations per 100 person years.
Okay.
When you look this multivariable adjusted model. So where like the reference group is important is when you're looking at relative rates or relative risks. So what you really saw was that the group that actually had the lowest infection rate, so a relative rate of 0.65 was the IL-17/23 group. So they were really you were less likely to have a serious infection on an IL-17/23. The group that kind of crossed one in that relative risk group were the TNFs, the older systemics, and then the methotrexate. And then the group that really favored a higher risk with the relative rate of 2.89 was tofacitinib.
Yeah, that all makes sense. Did they break out the IL-17s and the IL-23s at all?
They did, yes. So the IL-17's relative risk was 0.59. For the 12/23s, it was 0.68, but they had confidence intervals that were pretty, overlapping. So there really wasn't a big difference. There was not a big difference between classes when you looked at different drugs. So, things to consider. This is Canada, and people would have been mandated. I mean, not to knock Canada, I like the Canadians, but realize that, if you look at step therapy, everybody, probably would have had to have been using methotrexate or an older systemic medication at some point prior to getting on a biologic. So just keep that in mind. And there's been, changes in practice over time. This also didn't, account, this is non-randomized. So, it may be that maybe your sickest, elderly, most frail people don't end up going on like an IL-17 or IL-23. Right. So there's this healthy patient bias for newer biologics. So interesting.
I was surprised that the IL-17 and IL-23, that the 17, that they overlapped. I guess I had always thought of the 23s as being the least immunosuppressive, if at all. But this kind of says, they're about the same.
But serious infection, right? So I think if you looked at Canada, you're going to see a difference between those two. But these are things that land you in the hospital or kill you.
Okay.
So, why does this matter? If you look at a lot of clinical trials inclusion criteria, particularly for things like a JAK inhibitor, but a lot of times patients who are older than 65 are excluded, or there's an upper limit on age, and maybe it's 75. But so this was helpful to look and think about what about elderly patients. This would argue that their risk of infection is going to be lower if they have an IL-17 or an IL-23 versus other medications, and it really kind of drove home a pretty significant difference for tofacitinib.
Patton, is this going to change anything or?
Nope. We think those are safer, and we still do.
Yep. And I would, with atopic derm, when people hear me say JAK inhibitors they don't increase your risk of MACE or VTE, which is a controversial statement, but I'm comfortable making it. People often hear me saying that means that JAKs are safe. And no, JAKs are immunosuppressive. I mean, that happens to be a side effect we're more comfortable with, but JAKs are immunosuppressive, whether they cause MACE or VTE or not. All right, let's jump on to our next paper. Dr. Patton, what do you got?
My second six-pack was titled Safety and Efficacy of Prophylactic Topical Steroid Administration for Enfortumab Vedotin-Related Cutaneous Toxicity by Kita et al. The senior author was Kobayashi, that was Kaiser Soze's assistant in The Usual Suspects, and I wondered what he'd been up to. But it was published in the European Urology Open Science in December of 2024. Enfortumab vedotin is an antibody-drug conjugate used in the treatment of advanced urothelial cancers. Enfortumab is an antibody that binds to a protein called Nectin-4 that is highly expressed by urothelial cancer cells. Then it delivers some chemotherapy. I didn't write down the agent. It has a long name, so I didn't want to remember it. It delivers that chemo to particular cell.
So it's kind of like that old one we used to use in CTCL, where the
Dinomufin dufatox.
Yeah, so it's an
antibody now known as Lymphier.
I don't know, but it's an antibody that delivers the drug, so that in theory you prevent toxicity because the drug only gets into cells that are targeted by the antibody.
No, right. So I read something like antibody drug conjugates, like this is going to be the big thing. I don't know.
Yes, I think when you look at oncology meetings, antibody drug conjugates is that's the new wave.
Hot.
Yes.
Okay, so this antibody binds to Nectin-4. You know who else expresses Nectin-4? Keratinocytes. So these patients often develop cutaneous side effects, up to 50% in some studies. You combine that with Pembro, percentage of patients with cutaneous side effects could be as high as 70%. That's like 3 exclamation points. So this study enrolled 5 patients, 3 males, 2 females, which, you're looking at a drug side effect. You enroll 5 people, you're not going to see it. Well, they saw it. They saw it in 3 patients. So they applied petrolatum on one side of the body and clobetasol on the other side of the body. And Enfortumab rash occurs predominantly in intertriginous areas. So the patients only applied the petrolatum or clobetasol to the axilla and the groin. They did this for 4 weeks while receiving Enfortumab. 2 patients didn't develop the rash at all. The other 3, they didn't have any rashes on the clobetasol side, but they did develop a rash on the petrolatum side. Representative photos are shown. We'll put that up in the slideshow. So clobetasol prevents Enfortumab rash, and with such a high percentage, it seems like a crazy thing. Doesn't seem like a crazy thing to recommend to everyone on the drug, right?
Did they do the clobetasol? So first, yes. Did they do the clobetasol like just every single day, or was it 5 days a week? Or you may have said that I missed it, or what they did.
It was twice. Double check me on this. It was twice a day.
For 4 weeks from the start of.
For 4 weeks, because the dosing of the Enfortumab is week 1, 8, and maybe 21 or 15. And then if you give it with Pembro, you only get the 1 and the 8 dose. I think, don't quote me on any of the dosing.
So it's for the first 4. So it's for the 4 weeks after each dose.
Yeah, it's just the 4 weeks while you're on cycle, so to speak.
Yeah. So you get 4 weeks on, 4 weeks off, kind of a deal.
Yeah.
So that's just too risky. People are going to get stretch marks. I mean, that could be.
I know, right? Maybe. What Jakob Thiessen was like, clobetasol will kill you. I mean, it killed you. I think the takeaway I got from him. Maybe you go with TAC or betamethasone. Maybe you don't go full clobetasol.
Oh, come on. You go clobetasol. Go big or go home, Patton.
Yeah, I know. It was interesting. I've seen this. I've seen the Enfortumab rash. Pretty interesting. It was in the buttock area. And I thought it was like BP. There were these erosive, the pictures of the one patient, it's these erosive lesions, pretty painful. So if we're using more and more of this, we may be seeing this more and more frequently.
So then the other question becomes, does the clobetasol still help if you, once the lesions start, but it's not going to hurt. It's still reasonable to and then you would do it with future cycles, obviously.
Yeah. I mean, honestly, like, everyone using the clobetasol side did not breakout and the rash. I think in the petrolatum side where it developed, they like stopped the medication. They gave the patients systemic steroids. I don't know if it was a crossover where they started clobetasol. I mean, obviously it's a small study, short period of time, but yeah.
Okay. Useful for if we're seeing these people. Whenever you put this in as what you were going to do, my main response was like, what the hell is enfortumab vedotin? And yeah, now I know, and that's actually
everybody's going to learn something on this episode. That's right.
ADCs, antibody drug complexes. Okay.
Conjugates. Yep.
Conjugates. Okay. For our last article here, I've got one: efficacy of strontium cream in alleviating pruritus and hidradenitis suppurativa by Walker, Brooks, and Davlui. And Steve Davlui, and I have no idea how to say his name, really good guy at Wayne State who does a lot of HS. And the first question that came to mind for me is like, are HS people itchy? Like, and so, like, why are they doing this study? And so I went back. There was an article in 2017, American Journal of Clinical Dermatology, assessing pruritus and hidradenitis suppurativa, a cross-sectional study. And the big takeaways were this: about 57% of people who had HS had an itch score of at least 3. 3, so when you think of itch, you think 0, 1 is pretty much no itch. 2, 3, 4, probably 2 and 3 is mild itch. 4, 5, and 6 is moderate itch, and 7, 8, 9, 10 is severe itch. So almost 2/3 of people with 7% had an itch score of at least 3. The mean itch score was 6.1, which is actually pretty high. And whenever you really look at this, there were 2 big predictors: Hurley stage 3 in the groin. Those people, so Hurley stage 3 was like an odds ratio of 7 or 8 for having an itch score of at least 3. Hurley 2 was a odds ratio of, almost 2, about 1.69 to 1.8. And the vast majority of the itching was groin and axilla and buttocks, but groin was like by far the top one. And then again, by far, Hurley stage 3. And that makes some sense. So we know that scars can itch, especially scars that are inflamed. So makes lots of sense. So, okay, fine. I'm now reasonably convinced that at least for people with scarring from HS, they've got significant itching. And so then the efficacy of strontium cream. So strontium cream, this is Dermeleve, right? Hopefully most people at this point have heard of Dermeleve. We've had data since the 90s that strontium topically is actually quite effective for itch. It seems to be, it's a calcium mimetic, so meaning it affects calcium channels and calcium-dependent receptors, and those happen to be very important in itch processing. The data that we have historically for strontium is that it's very effective in itch in about 2/3 to 3/4 of patients. And so, they decided to do a study of it in HS. They enrolled these people from a support site called Connect HS. And that's a useful thing just to know that exists to send if your HS patients are looking for a support group at all. But so they used it to recruit people. Like they had a substantial number of people. They ended up including 50 in the study. And the big takeaway, so it definitely helped. So they only looked at 1 week follow-up. And this is an over-the-counter, so it's cheap, right? There's not going to be any funding for like a big or a long-term study. And the Dermeleve is actually really cheap. You can get it on Amazon or you can sell it out of your office. But the thing that I thought was most useful, so they did survey questions. And in the survey questions, did you experience an overall reduction in itch? 76% said yes, 24% said no. Did you experience a stinging sensation when you applied the cream? And that's important because Dermeleve stings like crazy if you put it on broken skin. And so 60% of people said yes, they got stinging. 40% of people said no, they didn't. So the majority did. Next question was, if you experienced stinging, was it worth the itch relief provided by the cream? And so whenever you look at this, about 20 people said yes, 10 people said no, and the other 20 people didn't have any stinging. So of the people who got stinging, 2/3 of them said that two-thirds of them said that the stinging was worth the itch relief. But then the most important question to me is, would you recommend Dermaleve to other HS patients? And 42 people out of 50, so 84% said yes, and 16% said no. So the takeaway here, if you got somebody who's early stage 3, especially in the groin, it's worth basically saying, hey, are you itchy? You might want to try this cream. And it's cheap. You get it on Amazon. It's extremely safe. I primarily use it for brachioradioparitis, notalgia paresthetica, and scalp itch. They've got a scalp serum that is really useful for the little old lady or little old man who's no redness, no flaking. Maybe you try clobetasol first and it doesn't work. Dermaleve is second line there. Had good success with it for scalp, but the strontium is an interesting thing. And we had, like I said, we have data going back to the 90s. It just took this long for somebody to really commercialize it. So really useful for any kind of neuropathic itch, genital itch, anogenital itch, lichen amyloidosis, brachioradioparitis, scalp itch, that kind of stuff.
You're saying it's good for itch.
For itch.
So you're saying it's good for itch.
Good for itch.
Not for inflammatory itch.
Not for inflammatory itch.
So we can break it down like atopic dermatitis, urticaria, that's inflammatory itch. Other things are like more neuropathic itch.
Yes, there are some people who use it for atopic derm. If you are going to use it for atopic derm, have them use steroid for a few days first, just to prevent the stinging. But it is a really useful drug in that sense. And also your sort of elderly itchy people and your diabetic itchy people. I do really like this company. I haven't really made any money from them, from drug talks or anything, but I just really
get on that.
They're too small.
A new Dupixent for you.
They can't afford me. But I do really like this because this came out about 5 years ago. And the first company that brought it out went bankrupt because they spent all their money getting it into CVS on the shelf. And these guys have done a much better job of like sort of shepherding it through Derm, keeping their costs way down. Because the key thing is just keeping it on the market because it really does help.
So how much does it cost? It looks like it's $25 on Amazon.
For which size tube?
Gosh, let's see. It looks like this is like 60 grams, so not bad.
Yeah, pretty. 60 grams.
It's expensive moisturizer, but cheaper than most copays.
Yes, and it truly. I mean, the active ingredient, the strontium. We've got good data going back 20 years. Like I said, they don't have the money to do like big studies at this point. And this when I talked to Steve, it's not like he got any funding from the company to do this. They just don't have the money to pay for this stuff. But we've got data from Howard Maybach, like I said, going back to the 90s.
Yeah. So this study, the thing I would say is like we have validated itch scores, which are 0 to 10. Why'd you go 0 to 5? Like that's if you have a validated score, just use it. Yeah. And then it's really hard with non-randomized studies. I mean, I think I like it. This looks like it was probably like a med student trial, and I like applaud students who try to take on things like a clinical trial. So I like it. But use the validated score when you got it. And 1 week in non-randomized can be tough, but hey, it's preliminary data, and that's where you start to figure out how to do things. So, and we need more research in HS. So good.
And this stuff, and it's cheap, right? So like $25 for a 60-gram tube, it really lasts people a long time. It's not like this is $80 for a tube of the stuff or something.
Right. It's not like that vitamin C serum I use on my face.
It looks amazing, Ferris.
Thank you.
Amazing. Amazing. Right. We got to get Ted Lane back on here. His skin was perfect.
I'll have a face off with him. Give me like another month of my serum. I'll be good.
All right. Well, we are going to wrap up this week's episode there. I want to thank everybody for joining us. If you got questions, comments, or ideas for topics we should cover on the show, shoot us an email at questions@dermsondrugs.com. I hope you learned a few things. I hope you laughed once or twice. And mostly, I'm hoping you're planning to join us next week. Until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.